Okay, so it's 12 noon. I'd like to welcome everyone to Medical Grand Rounds. This is our last Grand Rounds of the season. I'd like to thank everyone who has been here for the course of the year, and Grand Rounds will resume in September, and they will be hybrid, and we hope to see you there in person. Just before we get started, just a reminder that to please enter your questions in the chat at the end of the presentation, and please answer a brief survey that will be sent to you right after this presentation. And before we begin, I'd like to make a brief land acknowledgement. McGill University is on land which has long served as a site of meeting and exchange amongst Indigenous peoples. We acknowledge and thank the diverse Indigenous peoples whose presence marks the territory on which the people of the world now gather. Thank you everyone for being here today. Our speaker comes to us courtesy of the Division of General Internal Medicine, and I would like to ask Dr. Suzanne Morin, the Chief of Internal Medicine, to please present our speaker today. Suzanne?
Yeah, thank you, Nadia. Thank you everybody for being here. So it's my great pleasure to introduce Dr. Natalie Dayan, who will be presenting today. And Dr. Dayan is certainly a star among our division members. She's associate professor in the Department of Medicine, as you know, and is part of our division. She is importantly the director of the obstetric medicine clinical service, as well as plays a large role in trainee and training for GIM fellows, as well as internal medicine residents. And she takes care with her team of women with complex medical conditions during pregnancy and after pregnancy as well. And I suspect from the title here that part of what she will speak to us about is what happens also postpartum. She holds chercheur boursier clinicien junior 2 for her research on maternal outcomes and long-term women's health, and as a early career professorship in women's heart and brain health from the Heart and Stroke Foundation of Canada and McGill University. Her work is funded by CIHR and Heart and Stroke Foundation of Canada, and she's published successfully multiple times in important journals on her work. So it's my pleasure to introduce her and to allow her to present to us today.
Thanks so much, Suzanne, and thanks for inviting me to the last Grand Rounds of the year. And for allowing me to present my work. Thank you. Everybody hears me and sees my slides okay? I guess so.
Yes.
Okay, great. So these are my disclosures, but I have no conflicts of interest to declare. And you would have seen these learning objectives circulated. Many of you do not necessarily encounter pregnant women, but most of you do see reproductive age women and men, so in their reproductive lifespan. But today, the goal is to recognize the continuum of health and health care in the early and delayed postpartum periods, identify pregnancy-related risk factors for chronic morbidity, and appreciate the importance of breastfeeding for maternal cardiovascular health. And so we'll be talking about the transition from pregnancy to postpartum. And of course, I would be remiss to talk about transitions without speaking about our own transition that occurred in 2015 from the old Royal Victoria Hospital to the Glen campus. And what I'm showing you, for those of you who remember the F pavilion, so basically kind of like in the basement in the corner of the hospital, very far from the intensive care unit. And that's where the high-risk pregnant women were seen and delivered. Whereas now you can see on the right, the very bright, wide open spaces, which is the Glen Birthing Center and bariatric adapted. So a nice evolution and a great environment for this important part in a woman's life. So there are some key transitions that occur in the 4th trimester, and some of them are social. So going from childlessness or having one child to then becoming a parent of one or more children. Then there are many physiologic transitions that occur from the time of pregnancy and then delivery, and then towards the next phase of lactation. And in terms of the healthcare system, and that's really an area I've started to pay a bit more attention to, both in my clinical and research work, which is that, during pregnancy, women are exposed to often intensive monitoring. And in the postpartum period, it's sort of a, left to their own devices, which in some situations is appropriate, and in others, perhaps insufficient support. So in terms of the physiologic changes in the postpartum period, there are many. As many of you know, systolic and diastolic blood pressure changes throughout gestation, though probably not to the extent seen in this older study. But what really is the case is that those 3 to 6 days after birth, due to fluid shifts, use of NSAIDs, anxiety, and pain, there is a blood pressure surge. And women are often sent home in this period, and those who did not necessarily have a hypertensive disorder of pregnancy may not realize that their blood pressure is peaking, and it may be peaking to dangerous levels. Other changes that persist in the early postpartum period include an elevated heart rate, an elevated temperature, autodiuresis, uterine involution and contraction, breast engorgement, and then mood fluctuations, which start early postpartum and really can persist until the delayed postpartum period, or even up to 1 year postpartum. So what about healthcare in the prenatal to postnatal period? Those of you who have experienced pregnancy, either yourself or through a partner or loved one, might recognize this schedule. So this is quite an arbitrary schedule that was initiated in just before 2000, based on the March of Dimes, in an effort to improve neonatal and maternal outcomes. So kind of a structured algorithm of visits, although it is not necessarily based on evidence. And really all the guidelines will say that care should be tailored to each individual pregnant woman's need, but many low-risk pregnancies do follow this general schedule in which, there's well woman care in before pregnancy and a first antenatal visit at 12 weeks, visits every 4 weeks, and then as you reach the third trimester, every 2 weeks, and then every 1 week. What ends up happening, though, is that in the postpartum period, there aren't really any standardized visits other than the 6-week postpartum visit. That is sometimes challenging for patients to even organize. So in that postpartum, the focus is really on well baby care. So you'll notice the difference that preconception well woman care, then she's gone and had her baby, and then postpartum, the focus is often on well baby care. So a lot of visits for the baby, not a lot of visits for the mom in the postpartum period. So a big shift as well in healthcare, in the healthcare that is being offered. Many of you may have seen the Tiny Tot to Toddler book. This is handed out to every pregnant woman who has antenatal care. And I have to say that the 2023 guide has improved in terms of the information on self-care for mothers and fathers in the postpartum period, which is really fantastic. But really the focus still is on pregnancy health, peripartum health, and taking care of and feeding your baby without as much focus on maternal health. So why am I focusing on the 4th trimester today, what I'm calling the 4th trimester? So there are a number of reasons for this. And the first one is that we'll spend a little bit of time on, is that women still die or experience severe maternal morbidity after they've given birth. So the story is not over after they've delivered their baby. Women with severe maternal morbidity, and I'll define that for you in a moment, may have underlying chronic disease that was not previously identified, or after they've had their pregnancy complication, residual organ dysfunction, which we have seen, especially after preeclampsia, new chronic disease, post-traumatic stress, physical and mental disability, and also, importantly, poor social determinants of health, which both precede pregnancy and then are risk factors for future long-term health issues. Also, there's still a maternal child dyad in the 4th trimester connected by the breast rather than the umbilical cord. And then finally, it's important to focus on this time period in a woman's life because you're capturing women and their partners and their families while they are actively engaged in the system. We live in a city that does not have a high rate of GPs per patient. And so we know that a lot of patients do not have primary care. However, during pregnancy is a time when they really do engage with the healthcare system, engage with healthcare providers of some sort, if only for their baby and infant's wellness. So it really is an opportunity for positive health interventions and also risk mitigation. And as I've mentioned, there are care gaps in this time period. So I mentioned maternal mortality. So women still do die in the postpartum period. In fact, 50% of maternal mortality occurs after delivery and can occur by definition up to 6 weeks postpartum. Maternal mortality rate is typically expressed as the number of maternal deaths per 100,000 live births. And we're very fortunate that in Canada, we're in the blue here, which means we're less than 70 per 100,000, which is a WHO target. And in fact, we're closer to around 10 per 100,000. So, we still have maternal mortality, but the ratio is really quite low in comparison to the orange areas that you can see here, such as sub-Saharan Africa, which still have unacceptably high maternal mortality rates in the order of 1%. That is 1 in every 100 women who give birth in some of these areas die at the time of childbirth or soon thereafter. And this is a graph from the US, and it's similar in Canada. Maternal mortality has improved, again, a lot owing to this prenatal care algorithm and the March of Dimes. So maternal mortality has really declined over time, although you'll notice that there has been an uptick in recent years in the US. So since maternal mortality is thankfully rare in the developed world, in the global north, severe maternal morbidity, public health agencies have turned their attention to severe maternal morbidity. And this is a definition of severe maternal morbidity on the WHO website. It's essentially a near-miss complication. It's a complication that is an important public health indicator because it's an upstream event from maternal mortality. It's much more common, and so we can have an impact on it. As you can, if you remember, the rate of maternal mortality in Canada is 10 per 100,000, whereas the rate of severe maternal morbidity is orders of magnitudes higher, about 10 to 15 per 1,000 births in Canada. These are the common subtypes. Severe postpartum hemorrhage, which often turns into DIC. And this would be postpartum hemorrhage that requires an intervention such as hysterectomy or uterine artery embolization. Severe preeclampsia or eclampsia, severe sepsis or septic shock, and cardiovascular or circulatory. And these are also the most common causes of maternal mortality in the developed and undeveloped world. And so I mentioned that it's an upstream event, the severe maternal morbidity. And really, we should be thinking about capturing women earlier and earlier on this spectrum. Of course, we all want to avoid maternal mortalities. And so then we're turning our attention again to avoiding severe maternal morbidity, paying attention to early warning signs during key periods in a woman's trajectory during pregnancy, and then even earlier to identify and treat chronic or early pregnancy conditions before they evolve into these outcomes. So the Canadian definition of severe maternal morbidity has evolved. It was initially developed through a Delphi consensus, but is now a validated combination of ICD codes using the CIHR discharge abstract database. And it's a combination of disease specific and procedure specific and organ failure based definition. And essentially, these codes, so again, the subtypes, as I mentioned earlier, such as sepsis and severe preeclampsia with seizure or other severe morbidity associated with it, have been validated by having a high case fatality rate. So, for example, a death rate of almost 3 per 1,000 with someone who has severe maternal morbidity versus 0.008 per 1,000 among those who do not, and also a prolonged hospital stay beyond 7 days. Though uncomplicated deliveries are usually discharged within 24 hours, so more than 7 days is clearly abnormal. And so this is now the validated definition that is accepted by the Canadian Perinatal Surveillance System, which is a branch of the Public Health Agency of Canada. So what are some trends of severe maternal morbidity in Canada? As you can see, unlike maternal mortality, which has declined quite sharply over years, this has stagnated, and there's some worrisome kind of upticks, for example, the use of assisted ventilation or severe hemorrhage. So some of these severe maternal morbidity indicators are actually increasing or not decreasing, and a lot of that can be due to women entering pregnancy at older ages and with other chronic health conditions that are now surviving to reproductive age, or with the use of assisted reproduction, these women can become pregnant now. So women are entering pregnancy more complex, which means they are exiting pregnancy with more complications. So again, so a woman perhaps was, her life was saved. She had a severe maternal morbidity, but she survived to hospital discharge. So that's great, and we can all kind of congratulate ourselves, when an outcome like that happens, because sometimes these conditions can be quite severe and life-threatening. But the question then is, well, what happens to these women after they're discharged to that postpartum abyss without the really close surveillance that exists during pregnancy follow-up? So this was a question that a number of us asked. I, along with my colleagues, Robert Platt and others, asked this question: what happens after delivery hospital discharge to women who have these severe maternal morbidity complications? And the examples are listed in this orange box here. Our hypothesis was that there would be perhaps in some situations a lack of organ recovery, deconditioning, and poor cardiorespiratory fitness, endothelial dysfunction in the case of severe preeclampsia and placental-mediated complications, psychosocial stress, and mental health issues. And so we were our hope was to look at some of the health-related outcomes in using Canada-wide administrative databases, so CIHR, hospitalization and emergency room visit data sets, as well as the Institut Statistique de Québec in Quebec. As you know, Quebec is not part of CIHR. And we were also interested to look at health service use so that we could inform postpartum care pathways for women who suffered serious pregnancy complications. And this was a situation where we really worked closely with our patient partners, and we partnered for the grant, and also since the grant have been working with the Maternal Near-Miss Survivor Group, which is a group of 1,000 women who have survived a near-miss complication, either hemorrhagic or hypertensive or so on. And they have a very active Facebook group, and they're really advocates for women's health and for postpartum health. And we met with them a few times and asked them and polled their members about what mattered most to them as far as their health-related outcomes. And they really pointed to future reproduction as well as mental health as some of the key priorities for us to look at. And that's why these are some of the health-related outcomes that we chose to look at first in our study. And so I'm very pleased that our first Beyond paper has been accepted for publication at AJOG. And so I'm sharing with you the the preprint. This was led by Vivian Yuka, who came to give a lecture at CORE not too long ago and was a former postdoctoral student with Robert Platt and I. And we used a Quebec birth cohort using MedEcho of about 1.4 million women who had 2.2 million deliveries, spanning from 1989 to 2021. And our aim was to look at recurrent severe maternal morbidity. So what's the reproductive outcome in women who have these complications? So about 43,000 or 3% had a severe maternal morbidity in their first birth, and only 60% of those actually conceived again. And of course, we don't know if that's by choice or because they couldn't conceive again, but we did exclude people who had hysterectomies in our cohort. We then restricted the cohort to those who had 2 or more births, which gave us a final sample size of about 800,000. And what we found was that there is a relative risk of 3 of any severe maternal morbidity in the second delivery in those who had a severe maternal morbidity in their first delivery, compared with those who had none. And the absolute rates are 65 per 1,000 versus 20 per 1,000. So pretty high rate among those who had a severe complication in their first delivery. But what was perhaps a little more surprising is that we know that certain conditions like preeclampsia tends to recur. So it's a risk factor to have preeclampsia if you've had it before. But having severe preeclampsia or eclampsia in your first birth also conferred an increased risk of a discordant severe maternal morbidity in the next birth. So that's in orange, whereas blue is concordant. And if you can see, for example, having a cardiac complication, of course, puts you at risk of having another cardiac complication, but also puts you at risk of something else like acute renal failure or hemorrhagic complication. So that was sort of a novel finding in our study. And we were also able to provide quantitative estimates about the recurrence risk, which can inform counseling of women when they're thinking about getting pregnant again. We've also, performed a number of other epidemiologic studies, both using that Quebec cohort and others. And what we have found is that cardiovascular outcomes, such as cardiovascular hospitalization, is increased in individuals who've had severe maternal morbidity, notably severe preeclampsia or eclampsia, but even hemorrhagic complications and stroke in pregnancy. Others have shown that there is a pretty high readmission rate within 1 year of discharge, twofold readmission rate compared with individuals who had an uncomplicated delivery, and that all-cause mortality over 3 decades was twofold higher for individuals who suffered one of these severe complications compared to those who did not. And of course, this dissipated with time, but was still beyond the standard 6-week postpartum period. So again, indicating that that postpartum period, that 4th trimester, is really critical for surveillance. And the median time to mortality was 8.5 years compared to 14.6 years if you were affected by a severe maternal morbidity in pregnancy. And Asia Blackman, who's a master's student working with me in epidemiology, she's looking at serious mental health outcomes, which is one of the other outcomes that was noted to be important and relevant for the maternal near miss patient group. And it's unpublished data, but we did find a slightly increased risk of mental health hospitalizations and ED visits after severe maternal morbidity. Again, most salient in the first year postpartum. I'll just share with you a little bit more about this severe maternal morbidity and risk of mortality. This was a highlighted featured paper in Obstetrics and Gynecology, which is one of the journals for this field. And again, this was using a Quebec-based cohort of about 1.2 million births. And we looked at those who had any one of those severe maternal morbidity indicators versus none. We followed them starting 43 days after obstetric delivery, which is the standard period of time where you would sort of stop considering somebody as having a pregnancy event. And I shared with you these results. And what's really notable is that if you have any severe maternal morbidity, the risk of mortality between 43 days and 1 year was 6-fold higher. And then that risk sort of went down as you are more, as you're further from pregnancy. And you can look at some of the subtypes of severe maternal morbidity. So again, severe preeclampsia or eclampsia, but also hemorrhage and of course, cardiac complications and stroke and acute renal failure. If those occur during pregnancy, the risk of mortality is really quite high. So one of the most studied pregnancy complication when it comes to future health, both in the 4th trimester, so in the immediate postpartum period, but also the delayed postpartum period, is preeclampsia, which is, as many of you know, hypertension in pregnancy, along with proteinuria or other adverse condition. And it can be de novo or superimposed on chronic hypertension or gestational hypertension. But while 70% of individuals with preeclampsia normalize their blood pressure at 1 week postpartum, 70% normalize their blood pressure, there still remains an elevated risk for within the next 10 to 15 years, a variety of cardiovascular outcomes. So such as coronary heart disease, both fatal and non-fatal, stroke, arrhythmias, hypertension, heart failure, and other kind of end organ dysfunction. So preeclampsia is really particular in that it's a disease of the endothelium, and clearly there is some dysfunction and inflammation that persists postpartum, or women have chronic health conditions that are sometimes unmasked by the stress test of pregnancy. So what should postpartum care look like after a complicated pregnancy? About 15 years ago, I visited, just as I was starting out in practice, I visited Graham Smith's clinic in Kingston University, and he's an MFM specialist, so it's really quite interesting. But he's very interested in preeclampsia and long-term cardiovascular health. He noticed this early on in his practice, and he started to study his clinical practice. And he developed something called the Maternal Health Clinic, which is an initiative for cardiovascular risk identification in women with pregnancy-related complications. So he really started this whole notion of, cardiovascular risk screening and cardiovascular health improvement after pregnancy. And so it was a great clinic, and he actually published, his clinic procedures so that others can use it. And at the time when we were just starting in 2013, a number of us put together the Maternal Cardiovascular Health Clinic, which occurs at the Montreal General Hospital as part of the hypertension and vascular unit. And it runs about twice monthly. And we see women with hypertensive disorders of pregnancy and other related complications 3 to 6 months postpartum. So in the early postpartum period, we do see them in our antenatal clinic. But at 3 to 6 months postpartum, it's a perfect opportunity. Usually they're not back to work yet. And, the sort of baby fog has started to settle down, and it's a really great opportunity and a great time to be discussing lifestyle interventions, as many of these women are obese, and about a third have some chronic health condition that is identified at the time of this visit, be it secondary cause of hypertension, chronic kidney disease, or familial hyperlipidemia, or other cardiovascular risk factor that's unmasked. And so now a number of such clinics do exist across Canada, and we have formed the Canadian Post-Pregnancy Clinical Network, where we will be developing clinical practice guidelines in this area as it is growing. And I'm pleased to say that the 2021 lipid guidelines do comment on this. I was fortunate to work with Wendy Ray and Stephen Grover in our panel on pregnancy complications and future cardiovascular disease. And we do recommend a lipid profile 3 to 6 months after preeclampsia and other metabolic or placental complications. We do recommend counseling these women on their lifetime risk of cardiovascular disease, as their short-term risk is going to be underestimated, and we provide really enhanced education on lifestyle behaviors known to reduce cardiovascular risk. And then we have discussion about statin therapy, and this is a bit of a contentious area. The data are not there yet. However, what we do know are that some statins are safer than others in reproductive age women. For example, those that are hydrophilic, such as pravastatin, which are now even being studied during pregnancy for preeclampsia prevention, so can be offered to select women in their reproductive years. So we spoke about, postpartum care. We spoke about severe maternal morbidity and postpartum outcomes. And so something else I thought that I would like to share with you is that I've become increasingly interested in lactation and maternal the cardiovascular benefits of lactation. If postpartum care is sort of understudied, I'd say that lactation or breastfeeding is even more understudied and still remains sort of a taboo subject that many physicians are not comfortable discussing with their patients. And while we do know that the existing recommendations for breastfeeding for minimum of 6 months up to 2 years are really based on optimal nutrition for infant health and development, notably reduction in atopy and gastrointestinal infections. But there is evidence that breastfeeding supportive interventions can actually improve maternal cardiovascular health. So there's now kind of abundant evidence that I'll share with you. One is a systematic review, including over 1.1 million Paris women from 8 large cohort studies, including the Nurses' Health Study. And there was a meta-analysis done of these studies, published quite kind of contemporary evidence that examined the association between any breastfeeding and the incidence of cardiovascular events. And the cardiovascular events that were examined in these studies include coronary heart disease, stroke, and fatal and non-fatal cardiovascular events. And so what was found is that the pooled relative risk reduction of any breastfeeding versus none was modest, but still significant in preventing some of these hard outcomes like cardiovascular disease, coronary artery disease, stroke, and cardiovascular mortality. Of course, there was some heterogeneity among studies, so the I-squareds were above 70%. And also, although these are all adjusted estimates and adjusted for known confounders, this is still observational data, of course, and it's possible that there's confounding by indication in that women who choose to breastfeed longer may be more educated and take better care of themselves overall, although there have been great efforts to adjust for these other confounders. But there are possible kind of biologically plausible mechanisms of action for the association between breastfeeding and cardiovascular health. And one is the role of lactation in sort of resetting the metabolic changes of pregnancy, notably glycemia, lipids, and atherogenic lipid profiles and visceral adiposity. And oxytocin is increasingly recognized to have cardioprotective effects. So in terms of the metabolic reset, it has been shown to reduce it's mostly any versus no lactation, but there have been dose responses. The more duration, the higher duration of lactation is associated with a lower risk of these cardiovascular risk factors, hypertension, diabetes, visceral adiposity, and subclinical vascular disease, such as the presence of vascular calcification in some studies. So we performed actually a cross-sectional analysis of that maternal health clinic that is led by my colleague Graham at Queen's University. And he's collected data on all the women who've attended his clinic who have hypertensive disorders of pregnancy, as well as gestational diabetes and preterm birth at 6 months postpartum. And at that time, they were all asked about their breastfeeding status. And this is a cross-sectional study. So they were either did not breastfeed at all, or they were classified as having stopped breastfeeding before their 6-month visit, or they were still breastfeeding. And then he performs lipid panel and other metabolic measurements in all of these women. And you can really see the dose response of those. If you just look at, so for example, LDL is highest in no breastfeeding, and then lowest in those who breastfeed for 6 months. And systolic blood pressure is highest, again, even in the normotensive range, but higher in the no breastfeeding, and quite a bit lower in those who are breastfeeding for more than 6 months. And this is among women who have hypertensive disorders of pregnancy. And then the odds ratio for metabolic syndrome was lower in those who were breastfeeding for 6 months compared to none. So there does seem to be a protective effect in this high risk population. And so what about oxytocin? So oxytocin is the lactation hormone responsible for the milk ejection reflex, and it's released from the posterior pituitary in response to infant suckling, and stimulates smooth muscle cells around the milk-producing glands. But what we now know is that oxytocin receptors are present in the heart, kidneys, and vessels, and can and has been found in some small mechanistic studies to result in a reduction in peripheral vascular resistance and a lower blood pressure through releasing atrial natriuretic peptides and synthesis of nitric oxide and vasodilatation, and direct cardiac effects by improving cardiac output, reduction of cell death and inflammatory responses, and regeneration of cardiomyocytes. So very interesting potential mechanisms there. What is also interesting is that women with chronic morbidity, or women who've had pregnancy complications, who might benefit most from these cardioprotective effects of lactation, tend to have reduced lactation success. So decreased initiation and continuation compared with normotensive, and a number of different papers have shown this. And some of the explanatory factors that have been proposed include obesity and sort of the inflammatory milieu, as well as some like edema in the breast, use of beta blockers, which can impede milk supply, preterm infants who don't feed as well, and certain ethnicities that have been related to this reduced lactation success. So a number of years ago, we thought about, well, how could we improve this? How could we improve breastfeeding so that women who have hypertensive disorders of pregnancy and other metabolic complications can benefit from the cardioprotective effects? And so I'm showing you our study protocol, which has been published in BMC Pregnancy Childbirth for the She Matters study, which is a multi-center open label randomized behavioral trial that is occurring at MUHC, St. Mary's, the Jewish General Hospital, as well as Kingston General Hospital, and it's ongoing. We're 90% of the way through recruitment. And of course, you cannot randomly assign women to breastfeeding or non-breastfeeding. I shared with you earlier that, of course, there might be confounding by indication if we only do observational studies, but we can randomize them to a breastfeeding supportive intervention. So this is our team, our wonderful team. This is an RCT, which is testing a behavioral intervention to improve breastfeeding and blood pressure outcomes among women with hypertensive disorders of pregnancy. And it's using a self-efficacy enhancing intervention, which has previously been studied in healthy women, which includes face-to-face counseling and follow-up sessions by phone for 6 weeks, and then in-person or video conference follow-up, compared with usual postpartum care. And the outcomes are followed to 6 months with passive follow-up up until 12 months. And we also have, as part of our study, pragmatic follow-up for cardiovascular outcomes, where mostly unrelated to the breastfeeding, but where we are performing enhanced phenotyping of HDP women to see who really is destined to develop these cardiovascular events. And I'm very fortunate to be working with behavioral intervention experts like Dr. DaCosta, who I think is on the call, and Dr. Cindy Lee Dennis, a colleague of Debbie's for a long time and now a colleague of ours in this study, who developed this intervention. And we do also have, given that it's a behavioral intervention that's occurring at different centers, we have a protocol in place for assessing the fidelity. So each kind of intervener records themselves, and then somebody blinded from the team assesses their intervention using a scale. This study was actually supported by our feasibility pilot study of 45 women that occurred right around the time of the pandemic. So a lot of challenges completing it, but we did complete it. And we had to shift to perform remote visits and remote blood pressure measurement, which we now do for She Matters. So we had 45 women in this group and in the study, and they all had a hypertensive disorder of pregnancy. They had singleton births at least 34 weeks, and they intended to breastfeed, spoke English and French. And our targets were really feasibility and satisfaction, and we met our targets, which were a 50% recruitment rate, 83% retention, despite substantial challenges due to the onset of the pandemic. And 95% of mothers in the intervention group were satisfied, and 94 at the 6 month. What we did find was interesting, even though clearly the numbers are very small. These are just trends. The breastfeeding self-efficacy scores, so that's how confident a woman felt in her behavior, were higher in the intervention group. So not surprisingly, they had extra support, but they also were breastfeeding more. So the blue is the intervention group and the pink is control. So they were breastfeeding more at 6 weeks, 3 months, and at 6 months. But even more interestingly was that blood pressure, so elevated blood pressure or use of antihypertensive medication was higher in the usual postpartum group, so lower in the breastfeeding intervention group. But as you can see, that it was also lower across all different time points. So also an interesting trend there. So our co-primary study endpoints for the She Matters study are average systolic and/or diastolic blood pressure and the number of weeks breastfeeding. And we have some secondary endpoints here and some additional secondary objectives. These are our inclusion criteria. So we are essentially just, we've excluded twin gestation and those that are born before 34 weeks, just because breastfeeding is challenging, and maternal admission to the ICU for more than 24 hours, as they're often separated from their infant for a long time, or any contraindication to breastfeeding or active COVID-19 at the time. And so this is our study schemata. We have our phase 1 study, which we're 90% through recruitment, thanks to our excellent team. And again, this phase 2 is really a study in which we are looking at different biomarkers at baseline and performing phenotypic characteristics of women with HDP and following them up for some long-term health outcomes. So that's sort of the phase 2, which is unrelated to the RCT portion. So in summary, I think I've shown to you that the 4th trimester is an underappreciated time of maternal risk and also an opportunity to improve health. At least 50% of severe maternal morbidity and mortality occur postpartum, and severe maternal morbidity types such as preeclampsia, hemorrhage, and cardiovascular conditions are linked with long-term poor mental and physical health. And I think, but yet to be sort of determined, breastfeeding should be supported to improve cardiovascular health. So with that, I thank you for your attention, and I'm happy to take any questions.
Thank you, Natalie, Dr. Dayan, for this really outstanding lecture, but also beyond that for creating this team, bringing this team together, creating this team and showing us how, how much you can learn from patient care, from bringing patients together by having this great sort of story to tell over the course of the years. I think it's really, really impressive. So a good role model for lots of people there. So thank you for sharing that with us, and congratulations on the work that you've done. David Morris, has made a comment. There's a few really lovely comments in the chat. I have a question for you. I invite people to answer their questions in the chat. What impressed me as well is beyond the team that you've created with all the healthcare people and your trainees and your staff, you've also brought in patients into this, which I think is wonderful. Can you give us an idea about that experience and how you did that at the MUHC? Was there any help for that? I'd like to know a little bit more about how you did.
Thank you. Yes, I'm really happy to have done that, because it really enriched that study, and we really I feel I've shared that first paper with sort of the organizer of that group, and we really do keep in touch. So it's been really wonderful. It was quite honestly, nowadays for CIHR, patient-oriented research is really promoted and encouraged, I think rightfully so. So we actively seek out kind of support groups, and I think this just happened to be a really fantastic and engaging group of women. I think partly because having gone through something so life-altering, that sometimes people's response is to become involved and try and help support other future women in their situation. So it was I have to say it was really a little bit happenstance. They happened to be one of the junior members on my team noticed them on Facebook, and so we reached out, and it sort of occurred organically that way.
Fantastic. There's a question here about the differences in different communities, First Nation, Black population. And can you comment on that, please?
So, yes, unfortunately, in my work, I haven't really looked at First Nations groups. And for sure, they have very, very high rates of hypertensive and metabolic disorders, such as gestational diabetes. And so I think, culturally sensitive and outreach campaigns need to be developed for those communities, because, I think it's not a one-size-fits-all kind of approach. So I know that in the Canadian Postpartum Clinical Health Network, they are working on engaging with Indigenous communities throughout Canada. So hopefully we will start to see them being more involved in this postpartum care.
Fantastic. John Kimoff is asking about there are strong links between sleep disordered breathing and hypertensive disorders of pregnancies and the metabolic syndrome. Did you incorporate sleep assessments in your maternal health clinic?
So great question. And yes, I am aware, John, as you know, but we do definitely screen all of those who have persistent postpartum hypertension. We screen them at least with a stop bang, and then we send a lot of them to you and to your other colleagues to screen for sleep disordered breathing, both in pregnancy, but postpartum as well. So we definitely do.
Fantastic. And Mark Roger wants to know, first of all, congratulating you. And can you comment on the absolute risk versus relative risk of subsequent pregnancy CVD complications after placental-mediated complications, especially in the context of counseling women who've had these complications?
Absolutely. So the residents who joined me in this clinic learn that there's really the counseling approach is really sensitive and tricky. We do want to inform individuals about an increased risk, but we also don't want to scare people. And the absolute risk for all comers remains low. That being said, there are certain studies that have shown that the more severe your pregnancy, your placental mediated complication, the higher your risk of cardiovascular outcomes. So there's a really nice paper by Joel Ray and colleagues, a Canadian paper. It's about 10 years old or 8 years old at this point. But it does show kind of like a dose response effect. So it really does depend. And I try and take a very careful reproductive history as well as family history and all the other cardiovascular risk factors. We unfortunately don't have a good risk score to use, but I'm quite careful in sort of, I talk about predispositions and not necessarily about risk. Also, individuals who have recurrent placental mediated complications, so more than one, seems to really have a quite a stronger risk of future cardiovascular disease. So I think it's really important, again, to gather all of the information before kind of tailoring the counseling approach.
Just a couple more quick questions. Comments on resources available for psychiatrists, psychologists, for those who have mental health associated issues?
So we have in our study and in our clinic, we have kind of an algorithm that if they score above a certain level, like an EPDS score above 12, or if they indicated sometimes or more frequently for self-harm question, they get referred to psychiatry, or they also have like sort of a DESI is filled out for community social services. And we have a psychologist who works, who does group counseling for postpartum women, David Senior, who's been wonderful.
Fantastic. One last question here. Is anyone doing polygenic risk scores in this population?
Possibly, I don't know. I think that's a really great point, though. I know, Nadia, I've teamed up with your group in, I'm sorry, I'm forgetting the cardiovascular signature program, and I think they're probably working on polygenic scores and other kinds of algorithms. And so we're joining our She Matters group with the cardiovascular signature group. It'll be a small percentage, but we're hoping to capture women with pregnancy complications and then be able to discern their risk of cardiovascular disease.
Yes, so we're looking forward to seeing what comes out of that collaboration. I think we're coming close on the end of the hour. First of all, once again, Dr. Natalie Dayan, really outstanding lecture and research program, and I invite you to read some of the comments in the chat, all very favorable. Thanks for closing out the year on such a high, and for being a mentor to so many, so many junior people. Congratulations again on all the work you've done. It is the last medical grand rounds of the season. I'd like to thank everyone who's here, not just today, but who's participated over the last year, for all your input and your questions and your comments. Greatly appreciated you being there in the last year. And grand rounds will resume in September. These will be hybrid, but we do hope that we will be seeing you in person at those medical grand rounds, and we'll send a reminder sometime this summer to let you know when they begin, but it will be after Labor Day in September. Thanks again, everyone, for joining us. Thank you, Natalie, for an outstanding presentation. I wish everyone a great day and a wonderful and safe and happy summer. Thanks, everyone.
Have a great day. Thank you. Bye.